Yeah, hi Namrita.
Hello, ma'am. How are you?
Hope you are also doing good.
Yes, ma'am.
Namrita, just reach home. Give me 2 minutes. Huh? I will
Oh,
be. Huh?
sure, ma'am.
Yeah,
Sure.
yeah. Okay, my dear.
एक बार नमिता खाली चेक कर लो।
ठीक,
ऐसे। हाँ।
लाइक
हाँ, एक ही सेकेंड बेटा please। हाँ है नो प्रॉब्लम हो जाएगा। हाँ, है डेस्कटॉप पे। रख कर तो गई थी कि जिस दिन वेबिनार होता है उस दिन तो जरूर लेट होना ही होता है। क्या करूँ। हाँ। हाँ कर सकते हैं स्टार्ट नो प्रॉब्लम। हाँ।
so we are
या
live now.
या
Good evening, everyone. I'm Namrita Madish from MediSage E-Learning Private Limited. a leading platform dedicated to empowering medical professionals through knowledge sharing, expert insights, and digital innovation. In our today's esteemed Pearl series, it gives me immense pleasure to welcome Dr. Ritu Santwani, a name very well known to our Medisage community. Dr. Ritu Santwani, a highly respected obstetrician and gynecologist, infertility specialist, and sexologist. Dr. Santwani holds qualifications including MBBS, MD, FECOG, FIAOG, and Arts Singapore. She is the founder and CEO of 360 Degree Healthcare Studio, NUHS Singapore, and is recognized among the top 50 influential doctors on social media. Dr. Santwani also serves as the co-founder of MAM and is a board member of SWWC, bringing a wealth of expertise in women's health. Today, ma'am will be sharing her clinical experience and expertise on a vital topic, postpartum sexual health challenges. So, without further delay, I'm delighted to hand over the session to Dr. Ritu. Over to you, ma'am.
Yeah. Yeah. Thank you, my dear Namrata, for your kind words. And warm welcome to all dear friends who are constantly engaging with this Medisage, we can say the Medisage community. Now, I'm also taking regularly the lectures in this, as the Namrata and Diksha told me that, ma'am, instead of calling others, you also start taking some lectures. This is Diksha was constantly telling me. So today what we are going to discuss is a very important topic related to postpartum sexual health challenges. We all know that being as a gynecologist, yes, lot of patients are coming to us with a lot of problems in the I will start sharing the slide. First, I'm giving the brief introduction of the topic. So related to this postpartum, what we gynecologists are managing, that regarding her physical care, regarding her breast care, regarding her vaginal care, doing some cosmetic gynecology procedures also, like the tummy tuck operations, or we can say the mommy makeover we are doing post delivery. Now related to the sexual health problems, this is a topic which is usually not discussed in the commonly routine busy OPD. So what are these sexual health problems and how we can focus on that and how we can treat that? So related to that, I have made my presentation for today. So now without further delay, I will start sharing my screen. Just a second. Yeah. I'll make it full screen. Hope it is clear.
Yes.
Yeah. So friends, the topic which I have prepared, especially focusing with the what is the importance, what are the clinical insights for this postpartum sexual health challenges for the gynecologist. So in this lecture, I will take you into the deep dive into the postpartum sexual health challenges, exploring the various prevalence rates, key issues like dyspareunia, decreased libido, evidence-based treatment strategies like pelvic floor physiotherapy, medical interventions, routine screening, and essential patient education. Why I put this pelvic floor physiotherapy? Last week only, one patient has came to me with the problem of the postpartum dyspareunia. Then she told me that she has Googled and she has read somewhere that some other physiotherapists, especially who are giving for this pelvic floor physiotherapy. So now how we can incorporate that and what is the importance of that also I have included in my presentation. So come to the next slide. Yeah. So this postpartum sexual health is critical yet frequently overlooked aspect of maternal well-being. The transition to motherhood profoundly impacts a woman's sexual health function and satisfaction, affecting the overall quality of life, mental health, and relationship dynamics. So, what are the key challenges? As I just mentioned, the painful intercourse or the decreased libido. Then the prevalence of this has been reported 50 to 80% that some or the other form of the sexual dysfunction in the first year after childbirth, and these challenges are often persisting. Impact on well-being. Beyond physical discomfort, these issues affect the emotional health, self-esteem, and body image. Unaddressed, they can strain intimate relationships and contribute to anxiety and depression for new mothers. So, a lot of patients we are seeing with the postpartum depression also. So now my topic is, because I have made the presentation which has been focused for the gynecologists. So gynecologists are the uniquely positioned to address the postpartum sexual health. Their role extends beyond the physical recovery to include proactive screening, education, and intervention for sexual concerns. Integrating these discussions into routine follow-up appointments is essential for normalizing the experience and facilitating the early intervention. So, why it is important to address this healthcare gap? Despite of the high prevalence and significant impact of postpartum sexual dysfunction, definitely a considerable health gap exists. Gynecologists have a crucial responsibility to bridge this by fostering an open, supportive environment where the women feel comfortable discussing their sensitive topics and receiving the evidence based guidance and treatment. So, this is a duty of us, means we gynecologists, to initiate the discussion about this. And if there are any issues, then to solve this. So, I have divided this into few chapters, considering coming to the first category or the first chapter, understanding the landscape of postpartum sexual health. So, the overlooked dimension of postpartum care, the traditional focus is on the reproductive outcomes and physical healing take the center stage. Means whenever the patient is coming to us, if the normal delivery, checking of the episiotomy scar, if the cesarean section, what about the cesarean section scar, what about the involution of the uterus, we will focus on that. So missing element is the sexual function and intimate well-being, often neglected. So according to WHO definition, sexual health encompasses the physical, emotional, mental, and social well-being. So focus on all physical, emotional, mental, and social well-being. So now, as the topic is very vast, I have to cover in the half an hour. So I try to focus on the important points and what are the medications which are available in India. I will show in further slides. So the prevalence of postpartum sexual health issues, 48 to 60% with the sexual problems, the dyspareunia and the decrease in libido. Then 60% plus, of course, there's a study has been presented that mostly the dyspareunia, 25% with the urinary incontinence, and 10% has been reported with the fecal incontinence also. So now what is this comprehensive overview of postpartum sexual dysfunction? So there is a study presented by the Lehman et al. In 2021. For dyspareunia, 48 to 60% in early postpartum, with 20 to 30% persistent pain at 6 months, often linked to the perineal trauma, episiotomy, and instrumental delivery. So, friends, here we can see that mostly this dyspareunia problem is mostly in the first 6 months, but still in 20 to 30% cases it has been reported post 6 months also. Then coming to the another important is the low libido, affecting the 50 to 80% in the first 3 months postpartum, and 30 to 40% report sustainable low desire at 1 year also. It is, of course, we know that driven by the hormonal changes, fatigue, and the new parental role. As we all know, now post the birth of the baby, the mother's attention is towards the baby is more. So this has been reported 50 to 80% in first 3 months, followed by 30 to 40% in 1 year. Then come to this vaginal dryness and lubrication. The study has been presented by the American College of Obstetrics in 2021. This vaginal dryness and lubrication common in up to 70% of the breastfeeding women due to estrogen deficiency contributes to dyspareunia and decreased sexual comfort. Then anorgasmia and body image. Anorgasmia reported to 15 to 20% of the postpartum women. Negative body image, as we know in the pregnancy, the weight gain, the changes in the body shape, and self-consciousness. Negative body image and self-consciousness also impede the sexual confidence and desire. Then, as we all know, these issues are usually peak in the first 3 to 6 months, and in some cases, it has been up to the 1 year also. So the long-term follow-up is required. Then there are the geographic variations, demographic influences, delivery mode, and pre-pregnancy baseline. All plays an important role. That what are these factors earlier? So studies have shown, coming to this geographic variation, the European cohort study has shown, a European cohort shows the lower dyspareunia rates than North American, suggesting the cultural or healthcare access influences. Among this demographic, higher risks are linked to the younger maternal age, primipara, lower socioeconomic status, and pre-existing some sexual dysfunction. Then delivery mode, vaginal delivery, especially with the perineal trauma, is strongly linked with dyspareunia. C-sections can also causes issues due to fatigue, body image, and recovery. Then pre-pregnancy baseline, better recovery is seen in the woman with higher pre-pregnancy sexual function, highlighting the value of preconception and counseling. Then coming to the next point or the next important chapter in this is the common postpartum sexual health challenges. So as we have just mentioned, the dyspareunia, vaginal dryness, and pelvic floor dysfunction. Dyspareunia more in first and second degree tears, forceps and vacuum deliveries, improper healing process, and dryness, we know, the decreased lubrication due to hormonal changes, and breastfeeding induced hypoestrogenism, reduced estrogen levels, lactation-related changes, delayed tissue recovery. Then pelvic floor dysfunction, showing this organ prolapse, stress incontinence, and muscle weakness. Then this psychological and relation factors, the body image concerns, anxiety, fear of pain, postpartum depression significantly reduces the sexual desire and satisfaction. Then changes in the relationship role, responsibility impacts the intimacy levels and sexual satisfaction. So proper counseling is definitely is must in these cases. So now coming to the, as I have just mentioned about the delivery method and the breastfeeding, maternal age also important point. So advanced maternal age, lack of partner support, and negative body image significantly impacts the outcome. Then what is this patient's perspective and what are the barriers to care? So still the patient feel hesitant to approach a doctor and ask about this decreased sexual drive or the dyspareunia. So females reluctant to seek help. Many women hesitate to discuss the sexual concerns due to cultural stigma, embarrassment, and lack of accessible information about the normal postpartum changes. Feeling of isolation. Qualitative studies consistently reveal the profound feelings of isolation, significant unmet counseling needs among the postpartum women. Then the care gap, standard postnatal care protocols often completely omit the sexual health discussions, leaving the woman uninformed and unsupported. Now, how to break the silence, creating a safe spaces for honest conversations about the intimate health concerns. So, cultural sensitivity, understanding the diverse backgrounds, provider training, building communication skills, and patient empowerment, encouraging the open dialogue. So, yes, the role of both the gynecologist and the patient has to talk openly, and the gynecologist have some sufficient time with the patient to discuss all these issues. But in some cases, the gynecologist have to initiate the discussion whether they are having a complete sexual activity or not. They are feeling some dryness or some pain or there's a decrease in libido. So now what are the clinical, how can we assess this clinical assessment and what are the measurement tools? So friends, the female sexual health function index, so the comprehensive measurement of desire, arousal, lubrication, orgasm, satisfaction, and pain domains. So I have taken in the one lecture for this female sexual dysfunction where I've shown about this female sexual function index. Those who have missed can go through the old lectures of this MediSage platform only. I've done for the female sexual dysfunction. They can go through that. Sexual activity questionnaire, which is then focused on pleasure, discomfort, and habit patterns in sexual activity. Pelvic organ prolapse or sexual questionnaire, so specifically designed for the woman with pelvic floor disorders affecting the sexual function. Now, sorry for this slide, this is a little congested. The female sexual function index actually compromises the 6 distinct domains: desire, arousal, lubrication, orgasm, satisfaction, and pain. So in this, they focus on all the points. Usually this FSFI, female sexual function index, consists of 19 items, each scoring from 0 to 5 and 1 to 5 point on Likert scale. The maximum possible total score is 36, with higher scores indicating a better sexual function. So this female sexual function index scoring 26.55 or less is commonly used as a clinical cutoff to indicate the probable female sexual dysfunction. So again, I'm repeating, this is focusing on desire, arousal, lubrication, orgasm, satisfaction, and pain. So now how to incorporating the sexual health into the postpartum visits. Routine inquiry once we are calling the patient at the 6 weeks for the postnatal checkup. Sensitive communication using non-judgmental, culturally appropriate language to ensure the honest disclosure. Uh, Comprehensive screening assess the pelvic floor function, psychological factors, and relationship dynamics, creating a comfortable environment for these kind of the discussions. Now, how we can manage this? What are the management strategies and counseling? As we have just discussed, the counseling plays a very important role. Tender loving care is also very important. Now, what about the medications? So, coming to one by one, as I have initially mentioned about the pelvic floor physiotherapy, manual therapy and targeted exercises significantly reduces the dyspareunia and improves the overall sexual function outcome. Medical interventions, the lubricants and vaginal estrogen therapy effectively address the dryness in breastfeeding women. Targeted therapy addressing anxiety, depression, and body image concerns improves outcomes. So now what is this pelvic floor physiotherapy, PFP? So this pelvic floor physiotherapy, a specialized branch of the physiotherapy that focuses on the assessment and treatment of the conditions related to the pelvic floor muscles. For postpartum women, this involves evaluating the strength, endurance, coordination, and flexibility of these muscles, which can be affected by pregnancy and childbirth. The goal is to restore the optimal pelvic floor function and thereby alleviating the symptoms that impact the sexual health. So for this, there is a manual therapy, hands-on techniques to release the muscle tension, addressing for the scar tissue, either episiotomy or C-section scar. Then biofeedback is the using of the sensors that the physiotherapist will guide them. Some therapeutic exercises. In some patients, of course, some vaginal dilator therapies are helpful in the cases of the dyspareunia. Education and lifestyle, yes, of course, plays a very important role. The benefits of this pelvic floor physiotherapy: reduction of the dyspareunia, improved vaginal sensation, and management of the pelvic organ prolapse symptoms, resolution of the urinary and fecal incontinence, enhanced body image and confidence. So, usually this pelvic floor physiotherapy is given a comprehensive assessment, including the internal examination, a series of weekly or bi-weekly sessions, typically lasting from 6 to 12 weeks, depending on the severity and nature of the symptoms, home exercise programs, regular re-evaluation of the progress and adjustment of the treatment plans as needed. So this pelvic floor physiotherapy is either the bi-weekly or the for the weekly one session for to 6 to 12 weeks. And of course, that some home exercises has to be also explained by them. And so by this PFP, this will help in all the symptoms, and studies have shown that the conditions like dyspareunia, the success rate has been reported 70 to 90%, with the improvement in pain levels and sexual function. Early intervention is often associated with better outcomes. So, friends, again, this is a very congested slide because there is a lot of material for this to show about this estrogen therapy, for the medical interventions for the postpartum sexual health. Again, I will show the one more slide which is showing the all these. So, first, as we know, the topical estrogen therapy is primarily used to treat the vulvovaginal atrophy, a common cause of postpartum dyspareunia, especially in breastfeeding women due to low estrogen levels. So it works on increasing the elasticity and lubrication without much significant systemic absorption. So lot of vaginal creams, estrogen creams, which are having the conjugated estrogen are available. Some names like Ovestin having a 0.5 gram to 1 gram. Then vaginal tablets and pessaries. Of this one is the Vegifem is the estradiol 10 microgram pessaries are available. Usually this has been recommended one tablet inserted to be daily in 2 weeks, then daily one tablet daily for 2 weeks, then followed by the twice weekly for maintenance. Vaginal rings, though these are not easily available these days, the silicone rings which releases the estrogen continuously for several months. Then in this estradiol vaginal rings, which will helpful in the cases of the postpartum to relieve the immediate give the commonly used in the immediate postpartum, then cream and tablets. Then it has to be inserted in upper 1/3 of the vagina, had to be replaced every 3 months. So these are the some estrogen preparations which are available. This is the some standard dosage has been recommended, but we always decide the dosage and duration as per the patient's symptomatic improvement and patient's body weight also. If the BMI is high, then accordingly we have to increase the dose. So then this topical estrogen therapy, as I just mentioned, so then this the estriol 1 milligram per gram, the cream is available. The dosage has been recommended 0.5 gram to 1 gram, applied intravaginally for 2 to 3 weeks, then reduced 2 to 3 times per week for maintenance, applied using an applicator on bedtime. Then estradiol vaginal tablets, one tablet of 10 microgram inserted intravaginally daily for 2 weeks and then twice weekly for maintenance. Then silicone rings, these days these are not easily available. Then studies have shown that topical estrogen therapy impact and guidelines. So only to be contraindicated in the cases of the undiagnosed abnormal genital bleeding, active venous thromboembolism, liver disease, and some estrogen dependent neoplasia like breast cancer, endometrial cancer. Then coming to this lubricant, friends, besides this estrogen in some patients, yes, especially this testosterone therapy has also been and come into the uh, limelight still, but a lot of the research is going on for the post, because usually we are giving this testosterone gel in the patients of the menopausal ladies with this with sexual dryness or with vaginal dryness or the decreased libido. In both the cases that is helping, but still some studies are going on, not a conclusion for this that they can be used immediately for the postpartum sexual health also, because this time we have to remember that lady is already breastfeeding, so whatever the medications we are giving, that should be safe, not only for the mom but for the baby also. Now coming to the lubricants either the water-based, silicone-based, or oil-based are not recommended. This lubricants offer the immediate temporary relief from friction and discomfort during the sexual activity, especially for postpartum vaginal dryness. Then water-based, most commonly safe. Water-based lubricants are safe with the condoms and sex toys and easy to clean. There are a lot of brand names are available. Then silicone-based, also longer lasting, waterproof and safe with the condoms. And then oil-based are not recommended because they will disrupt the vaginal pH and increases the infection risk. Hmm. Then among this vaginal moisturizer, the some brand names I have mentioned, the repellents what we are using very commonly and hydrogen. So typically applied intravaginally every 2 to 3 days and with one applicator for proper placement, ideally at the bedtime. It can be used, moisturizer can be used alone or along with the estrogen therapy. We have to educate the patient about all this and advise the patient that the products what they are using should not be having any strong perfume or parabens. Then coming to the other medical treatments, what are the other medical treatments are available for this? Uh, we have seen the studies have come for ospemifene. So the studies have shown that yes, oral selective estrogen receptor modulator (SERM) for moderate to severe dyspareunia due to vulvovaginal atrophy in postmenopausal women, not suitable in the for breastfeeding women due to systemic side effects and requires the strict medical guidance. Then intravaginal DHEA, progesterone, a vaginal steroid converted locally into the androgens and estrogens approved for dyspareunia due to vulvovaginal atrophy in postmenopausal women. But this is not suitable for the breastfeeding women. Then pelvic floor relaxants I have just mentioned. Then, yes, of course, the counseling and patient education is very important. So, for normalizing the changing timing guidance and communication enhancement. So, in amongst the timing, the physical readiness assessment, emotional preparation, and partner communication is also very important. So, integrating the sexual health care into the postnatal care by the gynecologist, by the psychological support, by the for the mental health psychological support and counseling, and physiotherapist for the pelvic floor physiotherapy. So, friends, I tried to include all the things as much as possible. So, then comprehensive treatment approaches. So among this, as I have just mentioned, again, I am showing this in nutshell, the topical estrogen therapy or the lubricants among the estrogen therapy. Yes, of course, the earlier we have used in our PG days also, the Premarin cream 0.5 gram to 2 gram intravaginally 2 to 3 times per week, vaginal tablets and vaginal rings. Then lubricants, water-based, silicone-based, not the oil-based. So they offers the immediately the symptomatic relief by reducing the itching and friction and improving the comfort because as some patients will complain of itching also. Then this pelvic floor rehabilitation protocols among this, as I just mentioned about this pelvic floor physiotherapy. So among this, the role of the Kegel exercise is also too good. Then we explain the patient for if the section scar is very bad or troubling, then the scar removal. Then usually while giving all these therapies, Kegel exercises or diaphragmatic breathing and stretch and postural connection, all should be used for 6 to 12 weeks. Significant improvement in many patients has been noticed. Then coming to this, I am seeing a lot of patients with this postpartum depression these days. Earlier, it was seen that if they are expecting the other gender of the child, and they are getting the, if they are expecting for the male baby and they're delivering the female baby, then they are seeing a lot of depression. But these days I am seeing in both the cases, even they get the hmm, um, so that's why accordingly we have to adjust and tell them. So psychological and behavioral intervention, the cognitive behavioral therapy identifies and modifies the negative thoughts and patterns and behaviors contributing to sexual pain and dysfunction, addressing the anxiety, fear, avoidance, and body image issues. So then mindfulness based techniques. So all this we have to related to all these things we have to discuss with the patient for reducing the stress and increasing the body acceptance, not only always going for the body shaming. Then couple therapy, of course, the couple counseling will be the much more better instead of only dealing with the female partner. So then elevating this postpartum sexual health. In clinical practice, sexual health represents a vital component of postpartum well-being that demands professional attention and expertise. Patient outcomes, early identification, and compassionate management significantly improve the quality of life and family dynamics. So, professional commitment also, yes, we have to start the discussion, initiate the discussion, breaking the taboos, and integrating some sexual health related questionnaire in the routine postpartum care protocols. So, together we can transform the postpartum care to address the whole woman, not just the reproductive health. So, of course, we have to ask and we have to initiate the discussion. So, now thank you, friends, for your attention, your time and attention. I know the topic is very vast. I try to finish up in the 30 minutes as much as possible. Uh, because what are the medications and recent treatments are available, I try to include. Still, lot of research are going on. Lot of patients, once we are taking the proper history and explaining about the dilators, also help them. And in some patients, of course, the use of the drugs is or lubricants is also helpful. Now we can see the questions, my dear. Okay.
Can I read it out, ma'am?
Yes.
Okay. Ma'am, the first question is, can SSRIs or other drugs for postpartum mood disorders affect sexual desire? And how do you manage this?
Okay, okay. Yeah, hi, Dr. Arjun. Thank you for joining. Yes, your question is very right. Yes, I have seen a lot of patients with SSRI, the postpartum mood disorders. So usually, I give in my practice as I just focused on that, for proper counseling, proper history taking, and uh, whatever the drug interactions we must know about that, what the drug is not good, what drugs we not give, and how I manage. I usually, mean, most of my patients, I start with the lubricants and moisturizer only. In only few patients, I will start with this vaginal preparations. Usually, somehow, by the grace of God, you can say, and the proper counseling, I am getting the good results with. And yes, one more important thing, besides that, I tell the patients a lot of dietary modification also. So instead of giving the estrogen only by the supplements, I will tell them the diet they have to start, which is rich in the estrogen. So the, as we know, the soya products are very good for that, and the other things, the flax seeds, and these flax seeds, fenugreek, these all are helpful. So I usually tell them the diet which is rich in the thing for the formation of estrogen. So usually I am giving them, and proper counseling and proper communication with both the partners is usually helping us.
Yes.
Okay.
Ma'am, the next question is, what is your experience with oxytocin nasal spray for
Okay.
improving sexual desire postpartum?
Okay, yeah. Hi, Dr. Meera. Dr. Meera, I haven't used for this sexual desire postpartum the oxytocin nasal spray. I had given in some patients the testosterone gel, and with that I find the good results, but I haven't used this oxytocin nasal spray. So let me know if you have used, how you are using, and what dosage you are giving, and up to how long you are giving. Besides it, before I will take the another question. So for taking in persistence of this Dr. Arjun and Dr. Meera, so usually as I told you that for this along with this dietary and proper counseling of both the parents, and I usually tell them for this to increase the foreplay. I have seen a lot of patients by increasing the foreplay, the problem of the vaginal dryness reduces. And in some patients, yes, of course, where there is a need of the lubricants and moisturizer, so don't hesitate to give them. Some patients I have seen the in the postpartum hypothyroidism flares up. So please, if the patient is coming to you with suddenly of this that decrease in libido, you have to inquire. As I've just mentioned about this either the episiotomy scar or the cesarean section scar. But besides this, also you go for through her hormonal checkup or hormonal milieu also. If there is any problem in that, don't hesitate. If there are a lot of changes, don't hesitate to take one opinion along with the endocrinologist also. Besides that, some Indian herbs like shatavari, ashwagandha, these also have a very, very good result. Haldi, because haldi ka lot of preparations we are getting these days. These all are very good for increasing the libido. So I am using that preparations also. Yeah.
Yeah. Now, ma'am, the next question is what role does mode of delivery, normal, vaginal, and cesarean, play in long-term sexual function?
Yeah. Hi, dear Rudra. Rudra, I think you must go through my slides. I have just shown in the earlier slides only. After presentation will be available on Medisage platform, the recording, or you can go through my YouTube channel. In the Medisage, if you can go through this, you can get the earlier my lecture of female sexual dysfunction also. Yes, as I just mentioned, yes, with the normal vaginal delivery, I am taking in nutshell only. So yes, the cesarean section scar, of course, in normal vaginal delivery, the episiotomy scar, and of course, in cesarean section scar, till the uterus get involuted. In some patients, is still the problem of the, especially with the episiotomy scar, the dyspareunia is there. So giving the proper counseling, proper dilators, and in some cases, and the use of the lubrication and moisturizers will give the good result. So this can be easily handled, not much difficult. Difficulty comes in the patients where even though they are having the uh, baby of, if they are waiting for the male baby and suddenly they are getting the female baby, the whole community or the whole family is against them, then the lady is suddenly going into the postpartum depression, lot of hormonal changes, lot of stress. So in that patients it takes some time. By rest patients, I think we can easily manage by this diet counseling and some lubricants and moisturizer. Yeah.
The last question is from Dr. Neil. He's asked,
Ah.
ma'am, in women with persistent pelvic pain postpartum, how do you differentiate between musculoskeletal, neurological, and sexual health related causes?
Neil, I must say this is a fantastic question, huh? So, Neil, usually in this patient, see, once I am checking, if I am finding that some musculoskeletal issue is there, then definitely I am starting the treatment. And related to some sexual health, of course, I am starting the some supplements, as I told you. But if I am having any doubt, I never hesitate to take us one opinion from the physiotherapist. So definitely I will, because I believe in the therapy where we are treating the patient, the multiple doctors are treating the patient. So I never hesitate to take a second opinion from the physiotherapist also. So I also suggest that yes, अगर कुछ भी ऐसा problem you have any doubt is like that, so please take one opinion from the physiotherapist also. If required, the pelvic floor physiotherapy they can advise. And they can advise about the sessions also, how many sessions the lady has to take, because being a busy practitioner in the obs and gynec and infertility, all the things we can't manage. Yes, if you are dealing only with this kind of the patients, then yes, there are a lot of laser therapies, lot of chairs are available, what we are using for the decreasing the incontinence, for giving the muscle strengthening. But in your question answer, I must say that please take one opinion from the physiotherapist also.
Yes, ma'am. These were the questions that we received.
Yeah, yeah.
Yes. Thank you,
So,
Dr. Ritu, for an insightful and clinically relevant session on postpartum sexual health challenges. And we deeply appreciate the time and expertise you've shared with MediSage community today. And to all our viewers, thank you for joining us today. And for those who missed the session, it will be soon available in the past events section on MediSage app. So don't forget to check it out. Thank you so
yeah,
much, ma'am.
yeah. Thank you, Namrata, and thank you, my dear friends, those who have joined. So, with this, we will wind off session for the today. Yes, still, if there are any queries, you can put on the MediSage app. I will try to reply as and when time permits. This is very important, as and when time permits, but I will definitely reply. So, with this, we will wind off for today. And in advance, next week, my Mata Rani is coming. So, happy Navratri to each and everyone. Till then, bye bye. Good night.
Good night, everyone. Thank you,
Good
ma'am.
night.